Welcome to The Explainer. Today, we are tackling a really important clinical topic: how to manage IBD medications during pregnancy. Our goal here is to give you the solid evidence you need to guide your patients with total confidence.
Okay, so let's jump right into a scenario that, trust me, you are absolutely going to face. A patient comes to you, she's thinking about starting a family, and she's worried. This question, it's filled with anxiety, and you need to have a clear, evidence-based answer ready to go.
And here it is. This is the one single most important principle that's going to anchor your entire management strategy. If you remember nothing else, remember this. Uncontrolled inflammation from active IBD is so much more dangerous to a pregnancy than almost any of the maintenance therapies we use.
So here's our game plan. We're going to cover this in 5 key parts. We'll start with that guiding principle, then we'll walk through specific meds, talk about the postpartum period, and we'll wrap it all up with a really practical counseling framework.
First things first, let's really cement this core principle. This is the why behind every single clinical decision we're about to discuss.
The point is, our number one job is to keep that disease in remission. That is the safest possible state for both mom and baby. Stopping maintenance therapy is just asking for a flare, and that's the one thing we absolutely have to prevent.
Okay, so now let's apply that principle to immunomodulators. And this is key. You have to know the difference between the agents in this class because their safety profiles during pregnancy, they are not all the same, not even close.
And the evidence here draws a really bright line. On one hand, you have mycophenolate mofetil. That's a hard stop, clearly contraindicated. But on the other hand, a super common therapy, like azathioprine or AZAC-P, actually has a great safety profile and is considered totally compatible with breastfeeding. It just highlights why medication-specific counseling is so important.
But what about the biologics? The cornerstones of modern IBD therapy. This is probably the biggest area of concern for patients, so we need to come to that conversation armed with the absolute best data we have.
And to get that data, we turn to a landmark study, the Piano Registry. Now, this isn't some small, retrospective chart review. This is a huge, prospective registry that was specifically designed to track outcomes and see how safe our therapies are in real-world pregnant patients with IBD. It's exactly the kind of evidence we need.
And the Piano Registry gives us this incredibly important finding. Yes, trace amounts of biologics can be found in breast milk, but, and this is the crucial part, these tiny levels do not affect infant outcomes. This is powerful, reassuring data that you can share directly with a new mom.
So let's pull all these findings together into some clear recommendations for that postpartum period. Because, remember, the goal of keeping the disease in remission doesn't stop at delivery. In fact, the postpartum phase is a super high-risk time for IBD flares.
This slide basically lays out your action plan. If you did reduce any doses late in pregnancy, plan on restarting the full regimen about 2 weeks before delivery. Then, keep that full treatment dose going all the way through the postpartum period to head off any flares. And you can confidently tell your patients that both azathioprine and biologics are considered safe for breastfeeding.
Okay, finally, let's pull all this information into a high-yield summary that's really going to empower your patient conversations. This is all about translating the data into effective shared decision-making.
Think of this table as your clinical cheat sheet. The main principle? Active disease is the enemy, so the goal is remission. For immunomodulators, you stop mycophenolate, as azathioprine is safe. And for biologics, the Piano data gives us a clear green light. Continue them, because they are compatible with breastfeeding.
And that brings us to our final thought. This isn't just data to memorize for an exam. It's a communication tool. When you're armed with this evidence, you can completely transform a conversation, taking it from a place of fear and uncertainty to one of confidence and partnership. And that is how we ensure healthier outcomes for both mother and baby.